Hello to everyone here in Portland and across the state. Apparently we're being cast in other cities. I want to thank everyone for coming. We actually have data to show that women and patients in general who are aware and more engaged in their health have better outcomes. They better understand their disease, the treatment, compliance is better, and outcomes are better. So kudos to all of you to showing up today. And I love today's topic. Actually, I was at a Komen meeting several months ago, and we were throwing out ideas for topics, and I thought a great topic would be emerging targeted therapies. And sure enough, shortly thereafter, I got a phone call or email that said, why don't you give that talk, Dr. Andersen? So it all worked out, so I'm happy to be here. We're not going to talk about the ER pathway or the HER2 pathway. I'm going to focus on beyond those pathways. And I know these conferences sometimes are challenging because we have newly diagnosed patients in the audience, and we have others who I can see in the crowd who can actually give the talk. So it's a spectrum of awareness and understanding. So bear with me that we're going to go beyond ER and HER2, which are kind of some basic pathways, and we're going to talk about new targeted therapies. I always show this slide at my talks. It's a very simple message to remind us of the prevalence of breast cancer. This is a survivor here. It doesn't project really well right here. She's had bilateral mastectomies, and she gathered 7 friends and titled the slide 1 in 8. 1 in 8 women will develop breast cancer in their lifetime. So the impact of that on a social level, financial level, health level is huge. It impacts not only the survivor, but also the family, friends, loved ones, the workplace, a huge social impact. So quickly, I want to just remind everyone that the current biomarker pathway for breast cancer is largely focused on the ER-PR pathway, the hormone receptor pathway. And we block that pathway with anti-hormone treatment strategies. Standard agents are tamoxifen, the aromatase inhibitors, which would be aromasin, Femara, and Arimidex, and Faslodex. We use those agents routinely in the clinic for disease that is ER-PR positive. HER2 positive disease is also a subset of breast cancer that encompasses about 20% of cases, and we now have targeted HER2-directed therapies, Herceptin, an antibody, Perjeta, another antibody, Kadcyla, an antibody chemotherapy conjugate, and lapatinib, a targeted agent as well. So we use those agents routinely in the clinic for the patients who have HER2-positive disease. But again, we're going beyond this menu today, but I at least wanted to reference this so those of you who are new to this topic are aware that those are current tests that we run on all the tissue and agents we use routinely in the clinic today, but we want to look beyond that. We need additional informative biomarkers that offer prognostic information and predict therapeutic efficacy. If you think back to the old days where we were not even aware of ER, PR, and HER2, all we had was breast cancer. We called it one disease, and we gave chemotherapy. Then we learned about the ER pathway, revolutionized a huge subset of patients because that's 70% of breast cancer. I have patients in my clinic today who I met, I'm thinking of one patient in particular, who I met 11 years ago when I joined this practice. She showed up to my clinic with stage 4 disease, ER-PR positive. She's actually triple positive, ER-PR positive, HER2 positive. She has never had chemotherapy. She's had her stage 4 breast cancer for 11 years, never has had chemotherapy because we've been able to manage her disease with targeted therapy that is ER-directed or HER2-directed. Then, a chunk of years ago, we learned about the HER2 pathway, and those agents really changed the landscape of HER2-positive breast cancer, higher risk cancer, and prior to that, we did not have directed HER2 therapies. Now we have several agents to choose from, and now we're looking for that next category. What's category number 3, category number 4? How can we further define other subsets and targeted therapies? So with that introduction, this is a slide kind of summarizing what I just said, that breast cancer is a spectrum of disease, hormone receptor positive, HER2 positive, and triple negative is about 15 to 20%. That is a group that tends to be more aggressive, and we do not have targeted therapies currently. However, it's changing. So again, we used to just have the hormone receptor positive, eventually the HER2 positive, but now we have a lot of other overlays, other terms that we're using that we're going to talk about today. One thing we're going to talk about is the Parp inhibitors, typically being studied in the BRCA mutated patients. but other agents that are targeted therapies. We're going to talk about the Pi3 Kinase AKT Mtor pathway. I know it becomes an alphabet soup, but just like ER, PR, HER2 used to be foreign words, we're going to have new topics to cover as well. So stay tuned. We're going to talk about several of these subsets as we go through our talk today. Here's the agenda. We're going to talk about the androgen receptor. You hardly ever hear about that in breast cancer, but there's a lot of evolving data supporting potential role in exploring that. We're going to talk about the HER family. I already referenced, I'm not going to talk about HER2, but there's more than just HER2. We're going to talk about the pathway I just referenced, the Mtor, Pi3 kinase AKT pathway, and inhibitors that are blocking that pathway that are in clinical development today. We're going to talk about CD4/6 inhibitors, one of which is currently clinically available. We're going to talk about immune therapy. I get that question multiple times every week. Doctor, what about immune therapy? Shouldn't I have immune therapy for my breast cancer? We're going to talk about that. We're going to talk about Parp inhibitors. That's all I'm going to talk about today, but there are more. I kind of ran out of time in covering all the agents, but again, a very complicated evolving landscape. It used to be very simple, but now it's becoming very detailed and intricate. So, before we move on, I want to talk about what is a pathway. When I talk about a pathway, I'm referring to I tell patients to think of it as a fertilizer signal through the cell. So in the example of the estrogen receptor pathway, here's a cell that has the estrogen receptor inside of it. This would be found in 70% of breast cancers. Estrogen can enter the cell, bind to that receptor, then through a complex communication with the DNA genome can lead to growth, proliferation, and tumor spread. So that's the paradigm of a pathway. So every pathway we're going to talk about is somewhat similar to that. A protein, in most cases, binds to a receptor, leads to some signal within a cell, and then a message to the DNA to affect cell behavior. So when I say pathway, that's what I'm referring to. However, it's not a simple one-way street. It'd be really simple if it were. If it were a matter of simply having a receptor here that leads to a signal and blocking the receptor at some level, that would be very simple. But we know it's not quite like that. It's more like this. There's crosstalk between pathways, and if you block one pathway, kind of like a traffic jam in Portland interstate system, if there's a car accident on the highway, people are going to exit and take an alternate pathway. That's what happens within a cell. The cell is smart. Its purpose is to survive, so if you block one part of the pathway, alternate routes are going to be upregulated. So that becomes really complicated when you're trying to develop a therapeutic agent that's going to affect a pathway, but you have to understand all the moving parts around that pathway, knowing that the pathway has interaction with parallel pathways. Very complicated. Here we're going to talk about some of these pathways. Here is that Mtor, AKT, Pi3 kinase pathway, which can run parallel to the HER2 and the ER pathways, so very complicated. And to add to that, I actually used this analogy a few years ago. I thought it was kind of cute and relevant, that Horton discovered a whole city on a fleck of dust. So imagine inside the cell, it's a similar story. It's a tiny, sorry, I keep pushing the wrong button. It's a tiny structure, but very complicated, and we're trying to map out that complex pathway system inside that cell. So I paint all this picture because people who are not in medicine sometimes will say to me, how come you don't have that figured out yet? Why aren't you working on that? Believe me, people around the world are working on this stuff. It's fascinating to go to the San Antonio Breast Cancer Conference, which is held in San Antonio every December. And you're in a room of 7,000 highly intelligent international investigators that spend their life on one doctor maybe spend their entire life on that little switch right there. So it's amazing, it's complicated, but again, we're making strides and huge strides. The landscape I showed you, it wasn't that long ago that we had a couple things to talk about. Now we have a lot to talk about. Okay. Let's talk about the androgen receptor. We think of the androgen receptor, we think of prostate cancer, and that's true. It's driven by testosterone, which binds to the androgen receptor, leads to a signal and cell growth. And we use agents that block that pathway in prostate cancer. We've known about the AR receptor in breast cancer since I was in training and even before that, but you never heard about any clinical implication or therapeutic intervention. However, it's gaining more traction. We know that it's expressed in 75% of breast cancers and 10 to 20% of triple-negative breast cancer. So the question is what if we were to block that? Would that have an effect in breast cancer? And agents have been studied. One is bicalutamide, otherwise known as Casodex, which is used in prostate cancer, and it shows some activity and some potential benefit. But I'm going to talk today about another agent, enzalutamide, as an example. Here's the overlay. Here we have a hormone receptor-positive breast cancer in the blue, HER2 positive in the yellow, triple negative over here. But look at AR. It's a big overlay with a lot of those other subsets. A concept in cancer management is back to the pathway picture. If we know that there is more than one active pathway in breast cancer, study after study has shown that if you block all of those that are active, you have better outcomes because you're blocking all the alternate pathways. If a tumor is ER positive and HER2 positive, we know we do better if we block the ER pathway and the HER2 pathway. If you only block one, the other one tends to upregulate. So this is a huge opportunity here with this overlay. What if we identify AR positive subsets that respond to AR blockade, and that can be used in combination with other blockade agents? So huge opportunity. Complex picture here. By the way, everyone should have a handout. I think I brought enough, and I know once you take those slides and shrink it down, it's hard to read, but the take-home point on this slide is that it's another complex pathway within the cell. I want to point out there are agents that are approved for prostate cancer, abiraterone over here, bicalutamide here, and enzalutamide here. They're all being studied to some degree in breast cancer. I'm going to give you some recent data from San Antonio and ASCO last year looking at enzalutamide. Enzalutamide blocks the access of the androgen inside the cell. Again, a paradigm in prostate cancer, but with the AR positivity in breast cancer, we're exploring that in breast cancer. And earlier studies showed that you can blunt growth if you block the AR receptor in tissue cultures in breast cancer cell lines. So a study was done. This was presented last year at ASCO, a huge international meeting. And they took women with breast cancer, stage 4, that were AR positive, and they treated them with enzalutamide. It's an oral agent. Think of it kind of like a hormone blockade for breast cancer, but of the testosterone pathway. So an oral agent, and they monitored response, and the endpoint was clinical benefit rate at 16 weeks. Clinical benefit rate refers to the tumor either reduced in size or it stayed the same. I always tell my patients in cancer, we like no growth. We want shrinkage, but if we get stability, we'll take that as well. So if you add shrinkage or partial response and stability together, we call that clinical benefit rate, or CBR. And what they showed was the clinical benefit rate was 35% at 16 weeks. This is a relatively heavily pretreated patient population. So now we're taking women, stage 4 disease, giving them an AR blockade agent, and they've kind of failed other therapies, and we're seeing a 35% response rate. That's pretty impressive with an agent that's oral and well tolerated. What they also found was, it's kind of scrunched down here, but they found the response rate was more robust if the tumor had a higher AR expression. If it was above 10%, they responded better than compared to under 10%. We've known that applies to the ER receptor. I tell a patient who is ER positive, if your tumor is highly positive, I expect a more robust response from anti-hormone blockade as compared to if your tumor is only 10% positive. So we're seeing that same signal here with the enzalutamide in breast cancer. So evolving target. Enzalutamide appears to have efficacy in breast cancer. We need to understand other concepts. We need to understand mutations, alternate pathways. Should we pair this agent with other pathway inhibitors, alluding to what I referenced, that if you block one pathway, other pathways can upregulate. So you may want to do a dual blockade, and that's under exploration as well. So stay tuned on the AR. It's not currently being used in breast cancer. There are trials exploring it, but I think in the near future, we're going to probably be testing AR routinely and exploring the option of AR agents in breast cancer. Okay, let's talk about beyond the HER2. So the HER family, which stands for Human Epidermal Growth Factor Receptor. We all know about HER2, but there's actually a HER1, a HER3, and a HER4. We call them collectively the HER family. HER1 is otherwise known as EGFR, and we have EGFR agents that block that pathway in lung cancer and pancreatic cancer. We also know that these receptors can crosstalk. So I'm not going to talk about HER2 directly today because we don't have time for that, but we can block the HER2 pathway with Herceptin, lapatinib, and Kadcyla. But we also know that if you block HER2, maybe the other receptors can crosstalk and develop alternate pathways. What we know is that the receptors can crosstalk, and they can crosstalk with a receptor in their own family, so a HER2 can talk to a HER2, or a HER2 can talk to a HER3, for example. We know that when HER2 talks to HER3, that leads to the most intense signal to the nucleus to tell the cell to grow. So a very good clinical question would be if the cancer is HER2 positive, maybe we should also block HER3. And that's exactly what was discovered and developed as pertuzumab or Perjeta. Perjeta is an antibody that prevents HER2 from talking to HER3. So the platform question was, what if we treat patients who are HER2 positive with Herceptin, so you block the HER2, but then to prevent the alternate pathway from upregulating, add Perjeta, which prevents the HER2-HER3 communication. And I'm going to go through a couple slides that looked at this combination in the preoperative setting. So we're talking about early stage breast cancer, HER2 positive, treating patients with chemotherapy backbone, but adding antibody treatment to that. The antibody historically would be Herceptin. So in this trial, the Neosphere trial, they used chemotherapy in combination with Herceptin as kind of the comparator arm, but as the experimental arm, they added the second antibody, the Perjeta. So they received chemotherapy and 2 antibodies compared to 1 antibody. And there was an improvement in pathologic complete response rate from 21% to 39%. What does pathologic complete response mean? We abbreviate it PCR. That means a patient has treatment preoperatively, and they go to surgery, and under the microscope, there's no cancer left over. That's what we want to achieve. We know that outcomes are better if women achieve a PCR with preoperative therapy. I always tell patients, if you don't achieve a PCR, it does not mean you're guaranteed to recur. The vast majority of women will not recur, actually. But if you have a group to pick, you want to achieve the PCR because they have the lowest rates of recurrence. So here we have a dramatic improvement in the PCR rate, almost doubled from 21% to 39% by simply adding another antibody. That's huge, okay? Actually, what they also looked at is the subsets, whether the tumor was hormone receptor positive or hormone receptor negative. Tumors that are hormone receptor negative tend to have a more robust response to chemotherapy-based treatments. And we see that in this trial here. If you look at the hormone receptor negative subset, their pathologic complete response rate, again, no tumor at the time of surgery, was 54% compared to the hormone receptor positive subset of 22%. So that's huge. We're doubling the PCR rate in this patient population by simply adding another antibody. Another trial, a Trifina trial, looked at a similar concept preoperatively, HER2 positive, chemotherapy backbone, different chemotherapy backbone, TCH, which is Taxotere, docetaxel, carboplatin, and Herceptin, and the Perjeta. So again, chemotherapy backbone, 2 antibodies, and they found also, looking at the subsets, an 81% PCR rate if the tumor is ERPR negative. Huge. Back when we just had Herceptin, it was around 30%. So now you're looking at adding an antibody specifically to the ERPR negative subset, which is historically more aggressive, and pushing the PCR rate up to 81%. That's impressive. Now, the hormone receptor positive patient population doesn't have a PCR rate as high. I always have to tell women who are ERPR positive, that's a good thing, because your tumor tends to be better behaved, and then I can treat it afterwards with anti-hormone therapy. But I have to coach them in advance to say, your PCR rate won't be as high as if it's ERPR negative. because it's a less aggressive disease and doesn't shrink as dramatically as compared to a tumor that's ER/PR negative, okay? So based upon these data, the NCCN has guidelines from FDA approved drugs to integrate Perjeta, the antibody that, again, blocks the HER2, HER3 dimerization in the preoperative setting. I'm not going through additional slides, but it's also approved in combination with chemotherapy in the stage 4 setting. So pushing the envelope beyond the historical standard of just ER/PR and HER2, we now have a new antibody on the market that is really pushing the landscape in managing HER2 positive disease. Can we even do better? Okay, so HER2 positive disease, we've dramatically changed recurrence rates by adding Herceptin and now Perjeta. However, there are still some women, about 26%, that recur after they've had standard chemotherapy and their 1 year of Herceptin. So standard treatment would be chemotherapy and a year's worth of the Herceptin antibody with integration of Perjeta since it was released. However, despite that, we still have some people who recur. And what we found was the highest recurrence rates, there was a spike in the year following the year of Herceptin. So we thought, maybe we should be doing something different to prevent that spike. They actually explored Herceptin for 2 years instead of 1 year. And 2 year was not better than 1. So just simply extending Herceptin did not add to did not blunt that spike. But is there something else we can do to minimize those recurrence rates? What they also found was the women who were, here's that spike I was referring to. So a year after completion of Herceptin, there's a rise in the risk of recurrence. And they also found that the women who were lymph node negative had relatively low rates of recurrence. So the platform for this trial was, let's take women who've had their chemotherapy, their year of Herceptin, and who are lymph node positive, higher risk, and add another drug to that. And the drug is neratinib. I think it was on the prior slide, I didn't reference it. Neratinib. Neratinib is an oral agent. It blocks the HER family. It blocks HER1, HER2, and HER4. So now we're talking about a more comprehensive blockade of the HER family. And the platform in question was, let's give a year of neratinib, it's an oral drug, after the year of Herceptin, and maybe we can further reduce the odds of recurrence. And here's the schema for the trial, the Exponet Trial. It was a year's worth of neratinib, 240 milligrams per day, versus a year of placebo. And it was blinded. We didn't know what the patients were getting. We kind of knew because side effects, which we'll talk about. And they were looking at the incidence of recurrence. And here we see at 48 months, there was a reduction in the odds of recurrence. 86% was disease-free versus 92%. So the neratinib group had lower risk of recurrence by adding that drug for a year after the year of Herceptin. I'm not showing all the slides, but this was a subset, actually, that looked at the hormone receptor positive subset. And that was the group that had the most impressive benefit. So the question is should neratinib, an oral agent that blocks the HER family, be added to women who've had their year of Herceptin, ideally the women who are higher risk, who are lymph node positive, and based upon these data, ER positive. And this is now under FDA consideration. It's not approved yet. They're expecting approval in the near future. And that will be a question, if you are in the audience and that fits your demographic, that would be a question for your provider to talk about that. Now, what we learned, though, is quality of life was not so good initially on this drug because there was an instance of diarrhea. That's why we kind of knew if the patient was on the drug or not, because if they're having diarrhea, they probably were on the study drug. We learned, however, if we integrate Imodium loperamide early on, quality of life kind of neutralized out and it was manageable. So there are studies ongoing to better understand the diarrheal component and how to best manage that. So in conclusion, I already kind of summarized the conclusion, is that neratinib is an agent that may be approved in the near future, that may become an added standard or to be considered in women that are HER2 positive, lymph node positive, ideally ER positive, to treat for an additional year beyond the year of Herceptin to improve outcomes. Okay, now we're going to shift gears to the concept of endocrine resistance. So over time, we know that if we use standard hormone agents like tamoxifen or aromatase inhibitors, eventually, in a stage 4 setting, those tumors become resistant. Or in the adjuvant setting, a woman may be on that pill to prevent a future recurrence, and unfortunately, they may recur. They may have developed resistance to that hormone blockade. So now we're looking at those alternate parallel pathways that may be linked to endocrine resistance, and maybe if we block those pathways, we can have a better outcome. That's this concept of dual blockade. And the pathway I'm going to talk about is this Pi3 Kinase AKT Mtor pathway. Again, here's that slide suggesting the pathway concept and crosstalk. So over here we have the ER receptor and estrogen combined to that. Again, it's not a one-way street, but it leads to a signal to the cell, and we can crosstalk between the ER pathway and the Pi3 kinase AKT Mtor pathway. So it begs the question, if we block or blunt this proliferation here, we may have a better outcome rather than just trying to block the ER pathway independently. So one agent that was studied and actually approved, and we now use in the clinic, is everolimus or Afinitor. It is an Mtor inhibitor. Mtor stands for mammalian target of rapamycin. We're going to call it an Mtor inhibitor. The concept was, let's combine the Afinitor, everolimus, with an aromatase inhibitor in the stage 4 setting and see if we improve outcomes. And we know that the Mtor pathway is dysregulated to some degree in 70% of breast cancers. So a huge opportunity to potentially pair blockade with standard hormone therapy. And this slide simply shows that concept of the dual blockade. And ultimately, the data were published in the New England Journal of Medicine. Everolimus Afinitor in postmenopausal patients, of course, hormone receptor positive in the stage 4 setting. And they showed that there was an improvement in clinical benefit rate. Again, that means the tumor either reduced in size or at least did not grow. They showed an improvement in clinical benefit rate, essentially doubled from 26% up to 51%. Huge. Think of stage 4 breast cancer as a chronic disease in some cases, like the patient I just referenced who's 11 years out and has never had chemotherapy. You want to take all of the therapies you can offer a patient, think ahead on how you want to sequence them, not burn a bridge, and add to each sequential independent outcome. So if we can give a patient aromasin by itself, or we can say, gosh, we have this data, and I can give aromasin in combination with Afinitor and double the clinical benefit rate, why would we not want to do that, right? So that's exactly what the study showed. And there was also an improvement in what we call progression-free survival from 3.2 months to 7.8 months. I know numbers and stats are challenging and difficult. I just talked about a patient who has had no chemotherapy for 11 years. So don't look at this and say, oh my gosh, with hormone therapy only, we get a PFS of only 3.2 months. These were women who had prior hormone therapy and who had failed. So you have to keep that in mind, but also that's an average. There are some women who don't respond, but some women who respond for many, many months or even years that kind of lead to that average. The take-home point is that we improved the PFS, the progression-free survival, from 3.2 months up to 7.8. And if you can do that with that therapy, and then upon future progression, add another therapy, and another therapy, and another therapy, then all those doubling effects become significant over time. So let me backtrack. So this is now in the clinic. We use this in the stage 4 setting. It's under investigation in other settings, in other combinations, but right now the FDA-approved combination is aromasin and Afinitor in the stage 4 setting with prior progression on other hormone-based therapy. New topic. This is exciting. There's so many topics to talk about. This is another pathway or concept. It's called the cyclin-dependent kinase 4-6 pathway. If we go back to 8th grade biology and the cell cycle, the cell goes through a normal development cycle, and what the CD4-6 kinase inhibitors do is they prevent or slow down the cell cycle progression from the G1 phase to the S1 phase. So it kind of slows down the normal cell growth. So the question was, what if we combined that with a standard hormone agent? And that led to the concept of exploring palbociclib or Ibrance. And this is highlighting the concept of adding letrozole or Femara, which is a standard aromatase inhibitor, in combination with the CD4/6 inhibitor, palbociclib Ibrance, in the stage 4 setting. In this trial design, it was in the first-line setting. So stage 4 disease, no prior therapy for stage 4 disease, ER positive. Let's treat with either Femara alone or Femara and Ibrance. And the data were published in the Lancet Oncology. It was called the Paloma-1 trial. And we saw an improvement in progression-free survival from 10 months to 20 months, doubling. Huge again. Again, if we can add up all of these improved PFS outcomes, it translates to longer progression-free survival, which usually then translates to longer overall survival. So why would we not offer a woman that doubled benefit in the first-line setting? So this drug is now FDA approved in the clinic. We use it typically in the first-line setting. We have other women who maybe didn't have access to this in the first-line setting. So now they had standard first-line therapy, and now they want potential access of this drug in the second or third-line setting. We have to navigate that concept with insurance payers because the drug wasn't available when they were in the first-line setting. Personally, I have not had a whole lot of conflict or problem in getting that approved in that setting. Okay, now I'm going to go back to that Pi3 kinase AKT mTOR pathway. We're going to talk about a Pi3 kinase inhibitor, another concept that's evolving. This is the BEL-2 trial presented at San Antonio this last year, looking at a Pi3 kinase inhibitor agent called buparlisib in combination with Faslodex. Faslodex is an intramuscular injection given monthly that is a ER combustor, let's call it. So it works a little bit differently than tamoxifen or aromatase inhibitors, but the take-home point is that it blocks the ER pathway. The concept being, if we block the ER pathway with Faslodex, and then we block that parallel pathway with a Pi3 kinase inhibitor, maybe outcomes are better than just blocking the hormone pathway alone. You're getting a theme here. Okay. And here's that internal cell picture kind of showing the same pathway concept again, blocking the ER here with Faslodex and now blocking the Pi3 kinase pathway with buparlisib. And they were randomized to all patients received Faslodex, fulvestrant, half received buparlisib or the placebo drug. And when they looked at the initial data, there was a numeric improvement in progression-free survival from 5.9 months or 5.0 months to 6.9 months. That doesn't sound that impressive. It actually was statistically significant, but we want to see more robust response than just 1.9 months. So we learn as we go, and we thought maybe there's a subset of patients in this trial that we can identify that are going to be better responders. So sure enough, they isolated out the patients who had PIK3CA mutations. That's a mutation in the Pi3 kinase pathway. And if we isolated the patients out that had the PIK3CA mutation, we saw a more robust response from a progression-free survival of 3.2 months up to 7 months. So that becomes impressive then. So again, we learn as we go along, and this drug and other Pi3 kinase inhibitors are under study. We may identify over time that first we have to test the tumor and prove that it has a PIK3CA mutation that may better predict response to the agent. Okay? So none of these are currently FDA approved. They are under study and probably will be approved in the future because the data are pretty intriguing. Let's get to immune. Again, as I referenced, patients always ask, what about immune therapy? Patients like that concept. It's something they can relate to. They're not going to come in and say, tell me about the Pi3 kinase pathway, or occasionally they do. But they all know what the immune system is, number one. And number two, it sounds healthier and gentler. Let's boost my immune system to help fight my cancer. May not be quite as easy as that, but it's a concept that's getting traction. We've been studying the immune system in breast cancer for decades. We actually have immune-modifying drugs approved for other cancers, for melanoma, kidney cancer, and lung cancer. We don't have any approved for breast cancer yet. Years ago, we kind of thought immune therapy was dead for breast cancer. However, there's kind of a resurgence now that there may be a role here, and we're learning more about it. I want to talk a few minutes about a couple concepts. One is TILs. What are TILs? And then the two receptors that play a role that we're going to talk about in the immune system are PD-1, which stands for Programmed Cell Death 1 receptor, which is seen on activated immune systems, or activated immune cells. So normal immune cells that fight infection or tumor express the PD-1, okay? Tumor cells may express PD-L1, the parallel receptor. I'll show you a picture, and it's called Programmed Death Ligand 1, and that's found on tumor cells, okay? Let's first talk about what TILs are. TILs stand for tumor infiltrating lymphocytes. So if you look at a picture of a cancer here, you see there's cancer cells there, but if you stain for immune cells, you actually can see speckled throughout the tumor are activated immune cells. So we thought, what are these immune cells doing, and is there something we can do to augment their effect if they're actually having a good immune effect on the tumor? And what we now know is that in general, the presence of TILs appears to predict for a better immune response. That's a huge, broad statement I just made. There's some conflicting data. We don't completely understand TILs, but the general take-home point today is that all the studies that have been looked at show that the presence of TILs, if you're on this side of the line, it means it's a good thing. The presence of TILs predicts for a potential better outcome. For whatever reason, if a tumor has tumor-infiltrating lymphocytes within it, in some way, shape, or form, that may be inciting an immune response that may control the cancer better than if there are no TILs present. Again, that's kind of a broad statement, but general concept. Are we okay on time, Jen? Okay. So that's a general concept. Let's talk about the receptors we're talking about. So again, here is an immune cell, a T cell, and it expresses the PD-1. And here is a tumor cell, and it expresses, or can express, PD-L1, okay? The way the PD-1 works on the immune cell is it serves as a receptor to kind of survey the environment and seek out stuff that shouldn't be there. And if it senses something that shouldn't be there, it may elicit part of the immune response. That's kind of a very simplistic description of that. The tumor cells are smart. They may express the PD-L1, and it can then bind to PD-1, and then it shuts off that immune surveillance. So the immune cell can no longer optimally survey the environment and elicit an immune response if it's being blocked. So, simple concept. What if we prevent that interaction between PD-1 and PD-L1? And we now have antibody drugs. We have anti-PD-1 antibodies, and we have anti-PD-L1 antibodies. Some of them are approved for other tumor types. They're not approved yet for breast cancer. They're being studied in breast cancer. But in the other tumor types, they have shown that that antibody blockade allows the immune system to target the tumor and control the growth versus not blocking the interaction between those two receptors. So that's a simplistic model of the concept, but that's kind of the take-home message. Now, one drug, pembrolizumab, which again is approved for other tumor types but not approved yet for breast cancer, is being studied in breast cancer. Here's a particular small study looking at pembro in triple-negative breast cancer, and not everyone responds. But when you get a signal like this showing, gosh, there are a subset of patients here, 18%, not huge, but what if we find a particular subset, 18%, that respond robustly to this therapy? We'd want to know that. So this was kind of a platform that led to further study design and development. This was a study presented by Dr. Rugo at San Antonio looking at pembro in PD-L1 positive. So they test the tumor cells, make sure they have that receptor, the PD-L1, and then they're treated with the pembrolizumab. In this particular trial, they were hormone receptor positive, HER2 negative. And here's that picture kind of showing the schema that we already discussed. the background information about Pembro and how it interacts with the PD-1 receptor, and the prior information showing some efficacy in triple-negative breast cancer, now exploring ER-positive breast cancer. And they specifically tested the tumor cells to make sure they were PD-L1 positive. Again, we're looking at a ER-positive subset, HER2 negative. And what they found was response rate was not huge, but a signal. 12% responded. Now, this is where it gets more complicated. These drugs are not benign. By modifying the immune system, you may have immune complications from these therapies. Not huge incidence, but these events can be problematic. So people can get autoimmune hepatitis, inflammation, irritation of the liver. They can have thyroid disorders. They can have pneumonitis, inflammation of the lung. Again, not numerically huge in incidence, but again, these are not benign drugs. So saying, let's boost my immune system can be a complicated endeavor that you have to be aware of the potential side effects. Another study that was presented looks at the opposite antibody approach, blocking PD-L1 instead of the PD-1. Avelumab was studied in this patient population, and the concept was based upon prior studies showing this blockade showed efficacy in other tumor types, and this was a PD-L1 unselected. For whatever reason, they said, we're not going to require the tumors to have the PD-L1, but we're going to look at a general unselected patient population, and we're going to require them to have prior chemotherapy, and we're going to look at outcomes. And again, not huge, robust response, but there were some patients that responded, and some were durable. So again, if we can identify those patients who may respond and get durable responses, that would be a more tailored therapy for that patient population. And of the responders, again, it was a small study, of the 8 responders, 5 had durable, meaning longer-term responses. Again, a reference to the fact that these drugs are not innocuous. They can have effect on the liver and respiratory effects, so we have to be aware of that. When they specifically went back and said, gosh, we'd like higher response rates, what if we assayed the tumors for PD-L1 expression, which they did, then they saw that the response rates were higher, 33%, kind of giving a signal to us that maybe the people who are going to respond best are those who are PD-L1 positive. So maybe that may become a biomarker, kind of like we test for ER and HER2. Eventually, maybe someday we'll test for androgen receptor, Pi3 kinase mutations, the PD-L1 expression, and then develop a personalized cocktail that's best for that patient based upon that tumor expression. So evolving observations and questions. We have signals of activity. These drugs are under study in clinical trials. We need to better understand the immune parameters. How can we better understand the TILs? If a tumor has no TILs present, are they not going to have an immune response? Those are questions we have to explore further. And should we limit our studies to those that are PD-L1 positive? We need biomarkers. And a trend now in all cancer studies is sequential biopsies. We want to biopsy a tumor, interrogate its features, treat with a certain agent, rebiopsy, interrogate again. Because we learn by gathering that information what effects we're having on the tumor. And that's kind of a common schema that we follow these days in our trials. Final topic. I'm okay on time? Parp. What is Parp, and why would we want to inhibit Parp? So back to 8th grade biology. Parp is an enzyme in cells, a normal enzyme. We all have it. It stands for poly-ADP ribose polymerase. The purpose of Parp is to survey your DNA for nicks or damage and then repair it. So you want to have a normal, intact Parp mechanism, okay? BRCA, so this is kind of related, so I'm going to talk about 2 things and kind of bring it together. BRCA is a mutation found in about 7 to 10% of breast cancers. If you are BRCA positive, it's a hereditary condition, higher risk for breast cancer and other cancers. If you are BRCA positive, you also lack appropriate DNA repair mechanisms, okay? So the concept being that if we inhibit Parp, remember we want Parp to repair damage. However, chemotherapy damages DNA, and that's how it kills the cells. So if you give chemotherapy to a cell population and you damage the DNA, and then PARP comes in and repairs it, maybe you didn't get the chemotherapy effect that you want. So if you can block PARP at the same time you're trying to maximize a chemotherapy damage effect, that may improve the outcome. Likewise, people who are BRCA positive, they inherently lack appropriate DNA repair. That's part of the mutation problem. So they are more at risk to, with their inability to repair DNA, if you can add a PARP inhibitor on top of that, you may augment the therapeutic effect. That's kind of the general concept. Okay, so here's a picture that kind of shows that. Here is the DNA structure, and the chemotherapy used in this picture is platinum. Platinum drugs are thought to potentially be more effective in BRCA patients based upon how the chemotherapy works. The chemotherapy damages the DNA, the BRCA cells can't repair it, so it may be a more effective chemotherapy cell kill. If you can add to that inhibition of repair with a PARP inhibitor, you may have a better outcome with a combination. So this is very hard to read, but this is a table showing that we have evolving phase 1, phase 2 data looking at PARP inhibitors in breast cancer. And across the board, response rates may be as high as 40%. Some trials showed 8%, some showed 20%, others as high as 40%. PARP inhibitors are not currently FDA approved for breast cancer. There's one that's approved for ovarian cancer, but not breast cancer. But we're trying to figure out, we're trying to better understand how these drugs may play a role in breast cancer. Some trials give us a signal of particular benefit, and then other trials show kind of conflicting information, so we're learning as we go. So lingering questions. Who should be appropriate for a PARP inhibitor? Should it only be BRCA-positive patients or triple-negative breast cancer patients? What stage of disease? Right now, most studies are looking at stage 4 disease, but there are some trials looking at PARP inhibitors in early-stage breast cancer, typically BRCA-positive patients. Should they be used as a single agent or in combination or sequentially with other agents like platinum-based chemotherapy? Again, these are questions we don't know the answers to yet. And what about long-term side effects? That becomes really pertinent when we're talking about early-stage disease. Those women are trying to cure. What if we give them a drug that has long-term side effects that we don't completely understand? So those are lingering questions that we have yet to identify. But stay tuned. Again, PARP inhibition, I think, will find a niche in breast cancer management. We're just still trying to find that niche. So back to a summary slide here. What we're trying to accomplish with these other concepts is to add to the ER pathway, to add to the HER2 pathway. What other pathways can we identify that are prognostic, that tell us information about how the cancer is going to behave, that are predictive once we develop therapeutics that block those pathways? That's the whole landscape right now of breast cancer trial development. Identifying dominant mutated pathways, reliable prognostic biomarkers that relate to that pathway, and then targeted therapeutics that affect outcomes and more tailored or individualized therapy. So I put this slide up just to show that at Compass Oncology, where I practice, we're part of a national network called US Oncologies, and we have a lot of clinical trials. This is a list. I don't even think it's complete. This is a list of trials we have going on now in breast cancer. And they're heavily populated with all these agents we've been talking about. You all now understand this alphabet soup. Here it is. Here we've got the star here refers to agents that are Pi3 kinase inhibitors. So we have several Pi3 kinase agents that are under study. I didn't talk about AKT, but AKT is part of the Pi3 kinase Mtor pathway. We have a preoperative AKT inhibitor trial going on right now. I have several patients on that trial. We're seeing really good response. It's an oral agent added to chemotherapy. Again, if we can give a targeted therapy with lesser side effects, with better outcomes, that's our goal. Here we have a PD-1 inhibitor that we're studying, PARP inhibition. So this is what the landscape looks like now. It's not just about ER, PR, and HER2. Those won't go away. Those are very effective therapies, but we need to explore other pathway dysregulation and develop therapeutics that target those other pathways. And I think that may be it. Great. So questions are written down.
Yes. So if you have questions, go ahead and write them, and somebody will be around to grab them from you, and we'll bring them on after Dr. Andersen to do a
Questions appropriate for an audience like this are ones that are more general concepts. Asking specifics about a specific case or a personal situation are not appropriate for a conference like this, but general concepts are great. Okay. Give me a minute to read the question. Okay, this question says, why not give neratinib and Perjeta to block HER1, 2, 3, 4 instead of Herceptin and Perjeta for all HER2 positive breast cancers to start with before finishing 1 year of Herceptin? Great question. So again, since those receptors can cross-communicate, the question is pointing to if neratinib blocks 1, 2, and 4, and Perjeta blocks the interaction between 2 and 3, would that be a more comprehensive blockade? I'm not sure that there's a trial specifically designed to assess that. There may be. There's always trials I'm not completely aware of. But stay tuned on the concept. There are lots of different combinations, permutations under study, and that may actually be under study. That's a very good question, and that's what led to the original development of Perjeta, knowing that the HER2, HER3 blockade is important. So great question. Neratinib isn't even approved yet. We're expecting approval in the near future, but that may become a concept moving forward, but great idea. This one says, are there correlations between autoimmune disease, such as thyroid disease and breast cancer? How does this work within the immune system or endocrine system? And any pathways that could be blocked for autoimmune disease? So yes, I would say that I'm not a rheumatologist, I'm not an autoimmune doctor, but they have similar agents in their clinic that they use that are immune modifying agents. So they're exploring these similar drugs as well. The first part of the question, are there correlations between autoimmune disease and thyroid disease and breast cancer? I mean, we've always wondered on what level is cancer immune related. And we've known for years that some cancers have a more immune regulatory component, kidney cancer, melanoma, and that's why, and now lung cancer as well. That's why those immune modifying drugs are now FDA approved in those disease states, because those are the ones that had a higher signal of having some immune correlation with it. So again, I think the role in breast cancer is to better understand the immune process in breast cancer and then target drugs that target that specific issue, which we're trying to explore. As far as relationship between autoimmune disease and breast cancer, I guess at a basic level, autoimmune disease refers to a dysregulated immune system. That's why people get rheumatoid arthritis, for example. There's something about the immune signal that recognizes joint tissue as being foreign and it's attacked by the immune system. That's a basic definition of what it is. What role does the immune system or lack of immune surveillance play in breast cancer development? I guess that's another larger question. We don't completely understand that. There probably is some link on some level, but I don't know that we can speak to that specifically. Do you have other questions? Is testing for AR positivity and TILs becoming standard? I wouldn't say it's standard. In my medical record that we use, which is a national-based medical record, you have a click box to click in there. Is the tumor ER positive, HER2 positive? AR is listed there now. It's not routinely being tested, though. We typically don't routinely test for something unless there's some therapeutic intervention or prognostic information gleaned from that. So I would say we're on the cusp of that, but it's not currently standard. Same thing with TILs. We have general data suggesting TILs may be a prognostic detail, but it's not going to implicate therapeutic decision-making at all at this point. So it's on the cusp, I think, but it's not standard. If not, what pressures are necessary to make them happen? What I just referenced. Again, until we better understand it, and know how to use the information and how to integrate decision-making related to that, that's when it will become standard. Now, in trials it's being done. So if a trial is looking at, for example, in the Pi3 kinase trial, there are trials now saying to be entered in the trial, the cancer must have the mutated Pi3 kinase gene. So in a trial, that's why sometimes if you participate in a trial, we have to get an extra biopsy to send off to get that tested. But routinely, that's not being done. And I think that's okay to not do it. There's no reason to do something if we don't even know what to do with the information. But I think once we understand that, it'll become standard. Next question, are your patients in trials tested for all of these? I would say not all of them, but if there is a marker that relates to that trial schema, then yes, it usually is tested. What is new for triple-negative breast cancer survivors to reduce recurrence? Everything we talked about today. So I didn't really title it that way, but as I referenced at the very beginning, we don't have targeted therapy for TNBC. However, all the drugs we talked about today, aside from the HER2 or HER family-directed agents, may have a role in TNBC. The Pi3 kinase, the Mtor, the cyclin 4/6, even though that was studied only with ER-positive disease based upon the currently approved indication, it's being explored in other subsets. So all these pathways, based upon the overlay I showed at the beginning, potentially have merit and implication in TNBC and are being studied there. Okay. This one's kind of specific, but since I don't, are there other ones? Let me jump to more general rather than being so specific. Someone asked about, can I get on a neratinib trial approaching my completion of 1 year of Herceptin? To my knowledge, there are no trials open because we have approval pending. So I would say stay tuned because they're expecting FDA approval potentially. I originally was told first quarter of this year, so it should be soon. So if you're wrapping up your Herceptin, then neratinib may be an option. A question always becomes, I finished my Herceptin a year ago. Do I now go on neratinib? It's kind of like when the Herceptin data came out, which now we use routinely if you're HER2 positive. A woman may have finished their chemotherapy and they're HER2 positive before Herceptin was approved. What we did in my clinic, even though there was no standard, is we called and contacted all women who were out a year or less and said, we have new data, come in and talk about it. Even though in the trials they started the Herceptin right after the chemotherapy, or concurrent actually in some cases, we thought that the data were so significant that we were going to invite women back who were out a year or less. That was kind of arbitrary. I mean, we kind of made up the year point. So same concept, I presume, would potentially apply here. This patient says, or an audience member says, if I'm not in the Compass network, can I come to Compass for a trial? Absolutely. Likewise, I have patients who I know of a trial at another location that I don't have access to, and by all means, I'll refer them. So I think the community is pretty collaborative. I have patients who will go to other locations within Portland or even fly to another city for a trial. So I think the community is pretty collaborative in allowing that to happen. This good question. It's prefaced by saying, I'm rather science ignorant, totally fine. Please forgive the question, the basic question. You said there are no immune therapies approved for breast cancer. Aren't Herceptin and Perjeta immune therapies? I wouldn't call them immune therapies. They're HER2-directed therapies, or HER2, HER3. And I guess it kind of boils down to how do you define the immune system? Because the immune system is thought of as the immune cells, but they trigger a lot of other activities and signals beyond their immediate effect. So I guess where you draw the line for the immune system is a little bit blurry, but I would say in general, most of us are not going to refer to HER2 or HER3 blockade as immune therapy. The immune therapies would be more of what we discussed today. What is the future of chemoprevention drugs? I attended San Antonio. I'm not aware of any any active additional chemoprevention trials that are, ready to be released or in design. I may be not completely up to date on that, but that was not a topic that was discussed. We do have chemoprevention drugs. We have tamoxifen, and we have Aromacin and Avista. Occasionally at a conference, we'll have a patient or a survivor stand up and say, why don't we have an effective drug that prevents breast cancer? All of those reduce the risk of breast cancer by 50%. Huge. But it's interesting, the number of women who choose not to pursue that. So high-risk women who've never had a breast cancer have the option to take one of those drugs and drop their risk of a breast cancer by 50%. They certainly have side effects. But the number of women who choose not to do that, but then turn around and say, why don't we have a prevention drug? Well, we actually do. Ideally, we want a drug that prevents breast cancer higher than 50% and has no side effects. We get that. We're trying to work on that. But we actually do have 3 relatively effective prevention agents. Of course, we want to do better, but I'm not aware of any drug in immediate development that would fill that space, but I may be wrong. This is a common question we get. What about the treatment or prevention using natural compounds? That's a tough one. What does natural mean? This is a concept that always kind of fascinates me. I collaborate with a lot of naturopathic providers. I think they do great work. I don't completely understand what they do because I'm not trained in that. Likewise, they don't know they don't understand completely what I do, but we partner together. But what does natural mean? Taxol comes from the yew tree. Taxol is a chemotherapy drug. It's natural. So I guess we all need a better definition of what natural means. Not everything that's natural is innocuous. I've had patients who've taken lots of supplements. I had one patient who went into liver failure on mushroom supplements. So natural does not mean benign, kind of like the concept of immune system. Let's boost my immune system. Well, the immune drugs that we're working on can have immune adverse effects. But I appreciate the question and I appreciate the concept. Certainly, are there things that we can do that are healthier and I'm going to use the word natural, but even though that's a blurry term, natural that may augment outcomes. And those are under development. We actually have a trial at Compass, and I think it's one of the first trials in our network similar to this. It is a Chinese herb study looking at a Chinese herb and its effect on fatigue in chemotherapy, in patients receiving chemotherapy. So what we need from those agents are better trial data. If you don't have trial data, it's hard to make recommendations. Oncology is probably one of the most data-driven subspecialties out there. We like data because we don't want to give things to patients without really solid data. What happens in the naturopathic world is I think there's lots of stuff there that has merit. But if we don't have what we deem in the oncology world as solid data, ideally blinded phase 3 randomized trials, then it's hard to comment on smaller case series or reports. That's why I allow my allow my collaborative partners to do what they do and allow me to do what I do, and we collaborate together. But at the end of the day, a lot of their data is not nearly as robust, and it's not a commentary on a lack of potential benefit. It's a lack of funding for appropriate research. That's why the trial I referenced is great that we're doing that study for that Chinese herb. It's a blinded, randomized trial, so we'll have data, and that's the kind of trial design that we need. Do you have any more questions? Why is there not a lot of information about triple-negative breast cancer? I agree, that's a common theme. It's just a lack of understanding. You know, it represents 20% of breast cancer, so it's not the most common subset. But we're on the brink of understanding that a lot more, showing you all the pathways we discussed today. All it is, someday that term will be non-existent. We won't call it that. Once we know a term to call it Pi3 Kinase AR positive, that'll be the new term for it, for example. So we're really on the fringe of developing information that would fill that space, but I think it's just a matter of science and understanding. What are the challenges of personalized medicine? So personalized medicine refers to what we kind of talked about today, better defining the tumor and selecting a treatment program appropriate for that individual tumor. You know, in the old days, it was you got this chemotherapy, and you took that hormone pill, and that's all we had. But now, with the pathway development we talked about, there will be a day where we'll say, you're one of the lucky ones that does not benefit from or does not need chemotherapy, but you're gonna have a Pi3 kinase inhibitor, a Parp inhibitor, and an AR inhibitor. And that cancer on paper, before all of that characterization, would look so similar to another patient 10 years ago who they all would have gotten ACT followed by tamoxifen. So it's a matter of reclassifying the landscape. The challenges are everything we talked about today: understanding the pathways, learning about them, what drives them, what are the mechanisms of resistance, and the interplay between the pathways. So everything we talked about today are those challenges. Okay, do you have any other ones there that are general-ish? Again, there's some here that are great questions, but I'm not sure that they're appropriate for a larger audience. Again, a few more questions about neratinib. I think I addressed that to the level that I think that's appropriate for a general audience. This question, it's kind of specific, but it's timely because we just got an FDA approval. It says, why would you choose to use letrozole Femara versus Faslodex fulvestrant with Ibrance? So the first indication was Femara in combination with Ibrance in the first-line setting, stage 4 disease. There now is an approval just recently released, the Paloma-3 trial, which used Faslodex, the intramuscular injection, with Ibrance. The indication is a little bit vague. It says progression on prior exposure to hormone therapy. So you technically can give that either stage 4 disease, on hormone therapy, you progressed, then you can give that combination, or you can even give it first line based upon kind of the vague indication. And literally that was just released this last week. So that's recent data. How would an individual doctor choose one over the other? I'll give you an example. I have a patient right now who I just saw recently who has recurred and has been off hormone therapy for several years, took the appropriate duration and then stopped, and now has recurred. So I could either follow the Paloma-1 schema and give Femara and Ibrance, or with the Paloma-3 data, knowing that some patients in that trial were similar to her situation, I could offer her Faslodex and Ibrance. And it comes down to understanding the data and the side effects. So if a patient prefers the oral therapy versus the intramuscular injection, or the side effects are different between the two and they favor one versus the other, I think it's open for discussion. Are we about wrapped up? 3 minutes. Let me see if I can dig another question here. So this says, patients who've had stage 4 disease and have never had chemotherapy, is that her personal choice, or would you prefer that she also attempt chemotherapy? Totally depends. So in a patient that I referenced one, but there are many like her, and oftentimes it's hard for patients to understand this. They come to clinic with their diagnosis, they know they have stage 4 disease, and they think, I'm gonna tell them chemotherapy. And the answer is no. If the tumor is ERPR positive, we routinely don't do chemotherapy in the first-line setting. We will if they have a high tumor burden, if they've got a lot of disease in their liver or their lung, or have a lot of side effects related to their disease. We may choose to treat with chemotherapy first, knock down the burden, then do the hormone therapy. But if they're not in immediate crisis related to their disease and they're ER positive, ideally highly positive, the standard of care is to not do chemotherapy first. There's no data to show that doing chemotherapy first followed by hormone therapy is better than the reverse. And as a matter of fact, we can spare a lot of women chemotherapy earlier on in their disease management if they get good responses to hormone therapy. And look at what we showed today. Some of those new agents where you pair it with another agent, we're doubling the clinical benefit rate or the PFS. So my response to that question is, why would I give a patient chemotherapy unless I think they need the chemotherapy? And in many cases, they don't. And hopefully they won't need it for quite some time. That wraps it up. Thank you for coming.